All right, it's morning time. Everyone's probably still hungry, or they've had their breakfast, hopefully. Hopefully having some GI activity. We'll talk about GERD here first. So what is GERD? We know it's our gastroesophageal reflux disease. We know that when we have this kind of chronic reflux of GERD, the gastric acid, we're going to see this mucosal damage that occurs. A lot of that can be due to either problems with stricture, or I guess closure of the lower esophageal sphincter. That can lead to a lot of issues there, where sometimes surgical interventions can come and help with that. Some of it could be also related to some medications, which we'll talk about. But essentially, this constant erosion of that mucosal tissue is what's leading to the pain and leading to the issues we see with GERD. And so we'll have some medications that can do with that specifically. So again, the pathophysiology, as we mentioned, is that retrograde movement of acid from the stomach to the esophagus. You also can have other things like pancreatic enzymes, bile acids, and so what are kind of the worst kind of outcomes from having kind of chronic GERD? Cancer can be bad. What else? Look how they get acutely killed them. Mallory-Weiss tears. Potential ulcerations, perforations, right? So all those can be really bad kind of outcomes from this. So obviously chronic GERD is not going to be a good thing, so we can hopefully give them some medications to help kind of limit that. And so you see kind of this imbalance between some of the aggressive and the defensive factors that are occurring within the stomach itself. So factors involved, we mentioned that the spontaneous transient relaxations of that lower esophageal sphincter. Some patients even have an atonic lower esophageal sphincter. You can also have some increases in intra-abdominal pressure that could force gastric acid up into the esophagus, anatomic factors, mucosal resistance, all kinds of different problems that can be affecting this. We'll look specifically at the composition of the refluxate, and specifically how a lot of our medications can kind of help with that, right? Because we can't fix kind of a wimpy lower esophageal sphincter. It's really going to be more in the realm of surgery, but certainly we can affect kind of what the stomach is starting to pump out in as far as acid goes. So this is a fun slide. What we're going to be looking at here is going to be some of our gastroesophageal, some of our gastric cells. So we have our parietal cells here, and we also have the paracrine cells. You guys have covered this at all yet in GI? So you guys are familiar with this. We'll talk about where the drug targets are mainly going to be in regards to this. But essentially, lots of different factors are influencing these cells to either increase release of gastric acid, or to help with the protective factors, the nice mucosal barrier, nice mucus barrier that we have that helps to protect the stomach lining from all these gastric acids. So some of the things that are involved in this include acetylcholine. Can be a big one. So by increasing acetylcholine activity at these muscarinic receptors, you can see increase in gastric acid. Just like after you eat a big meal, obviously it's increasing your parasympathetic nervous system. So muscarinic receptor activity is going to be high. We also have histamine is going to be a big one here. So notice our H2 receptors. Before we were talking about H1 receptors a lot in regards to allergies and in regards to sedation and things like that. Here H2 receptors are going to be the big one. Also, prostaglandins are important. We'll talk about specific medications that can be used to help treat chronic gastric ulcerations by using prostaglandins. And then gastrin is going to be a significant kind of positive activity here. Notice the prostaglandin itself is inhibitory. Kind of inhibits this second messenger cyclic AMP that works on the proton pump. So those are the big ones. Notice here, all these are going to have the activity on the proton pump itself. So when we say proton pump inhibitors, this is the pump it's inhibiting, right? It's bringing in potassium, kicking out hydrogen ions, which lowers the acidity of lowers the pH of the gastric acid, right? So that's the main pump we're going to be looking at. So you already can see where some of our drugs are going to be working at. You see where the H2 blockers are working at. You see where the proton pump inhibitors are working at as well. Also here you can see the epithelial cells that are responsible for producing that nice mucus barrier. So you can see prostaglandins and also the muscarinic receptors are important here in addition. Okay, so prostaglandins not only can help to increase the secretion of the mucus barrier, but can also help to decrease the activity of that proton pump. So, risk factors, we obviously know that things like obesity, delayed gastric emptying, pregnancy can all increase risk factors for GERD, but some of the behavioral ones are important as well. So smoking is a big one, alcohol use. We'll talk about certain medications that can worsen this as well, since those will be important when you're assessing your patient to see is there any kind of concomitant medications that are worsening this. So obviously, you guys all know, a lot of common foods that can worsen GERD. So things like, chocolate, fried fatty foods, alcohol, all the good stuff in life can worsen GERD. But certain medications, so things like anticholinergics can potentially worsen this. How do you think anticholinergics could do this? So not just histamine effects, but anticholinergics can, they can actually slow down the gastric emptying time, so you can actually keep stuff in the stomach for longer, potentially, which can worsen potential reflux there. It can also saw that you would have negative effects on the actual mucus barrier being produced on those epithelial cells, right? So muscarine acetylcholine on those receptors is important. Same thing can happen with narcotics and calcium channel blockers. They can slow down the GI tract, which can lead to more stuff kind of being held up in the stomach and can lead to that reflux occurring there. So it's a big one. Other big ones, we'll talk about bisphosphonates when we get to the osteoporosis section. That can be a big one just because of the fact that those pills, they have a very poor bioavailability, and they tend to get stuck in the esophagus, so you can actually see some esophageal damage actually being done directly by those medications. So that would be a big one we'll talk about there. Certainly aspirin and NSAIDs. We know that NSAIDs are important because they're inhibiting prostaglandins, and that's decreasing that gastric barrier as well. Okay, so lots of different drugs that can interact with this. Make sure you're assessing those patients for those interacting medications and see if you can do anything about those first. Okay, so our goals when we're dealing with GERD, we like to alleviate or eliminate our symptoms, decrease the number and duration of episodes. Hopefully we can help to promote the healing of the injured mucosa and then prevent any complications. So like the cancers, like the malarial lice tears, all those things we'd like to prevent if we can. So obviously our treatment options would include lifestyle modifications. I say boo to that. I still want to eat my curry and all the other bad stuff that's causing me GERD, right? I'm just kidding. No, just try to get them to change their lifestyle if possible. But if we can, avoid drugs if possible. But a lot of times you're going to need some kind of supplemental pharmacologic interventions there. Certainly there's some interventional therapy, so you can have like anti-reflux surgery, all those things like that. But I will not be talking about those too frequently. Certainly helping with lifestyle modifications, weight loss, elevating the head of the bed, different things like that can help. Obviously smoking and alcohol cessation will be big helps as well. And then obviously medications that have irritating effects on the esophagus, make sure you're taking with plenty of water. So that's like the bisphosphonates we mentioned, kind of getting stuck in the esophagus, that's a big one you want to take with lots of water. So the big drugs we're going to talk about for this class are going to be our antacids. We'll talk about the H-Receptor Antagonist, proton pump inhibitors. Then we'll talk about some prokinetics and the mucosal protectants specifically. Okay, so any questions from stuff from last week?
I don't remember last week. But
you don't remember last week?
If we have like a long an NSAID with a long half-life, like Daypro, are we worried about it building up in the system and having worse GI effects?
Yeah, so
taking it every day.
Yeah, so that's a good question. So they usually will, because obviously the longer the half-life, the higher the steady state is going to be when you finally reach that steady, right? Because it takes longer to get that steady state as well, but the levels will build up over time. Usually the dosing is set to where that's not really an issue, right? So they've already kind of done those studies where they figure out what the optimal dosing and the frequency is in order to kind of limit those kind of side effects.
So we dose like 1 every 3 days.
Usually not like that, but they might use a smaller dose, so that way by the time you get up to a steady state, it's at a decent level where you're not going to see any increased incidence of that, right? Because usually a lot of those drugs, when they do like comparative trials, one of the things they're looking at safety comparisons as well to make sure you don't have something that has like way worse GI effects or something. So like something like Toradol, we know it has worse GI effects, and that's why we limit it to 5 days of use instead of using it, consistently all the time. But something like that Daypro, is not really seen to be associated with that as much. Any other questions? All right, so we're going to continue with our talk of GI matters. So we're talking about GERD, which is, we're having excess acid being produced here. And so some of our basis for therapy, there's kind of 3 mechanisms we're going to focus on. One directly will neutralize the excess acid. So can you guys think of any drugs that might do this?
Zantac, Peptic, Nexium.
Not yet. That's going to deal with acid secretion.
Tums and Rolaids.
Tums, Rolaids. Okay, good. Yeah, milk can be a good one. So these are things that will directly, these are a lot of salts, a lot of basic compounds that are going to be directly neutralizing the acid. We're going to have things that reduce gastric acid secretion, which includes
Zantac, Peptic,
Yep, fantastic. And then we'll also see our PPIs fall into that category as well. And then we'll have some drugs that help to enhance that that kind of mucus barrier defense that we have in the stomach. Okay, so Carafate is a good one. Yep. Alginic acid, sodium alginic acid is another good one. Also, we'll see like some of our prostaglandins come into that category as well. So neutralizing the excess acids, so the antacids, does that make sense, will neutralize them directly within the stomach. You're going to see that the main differences, and there's several compounds that go into this category, you'll see that they have different neutralizing capacity, so obviously not all of them are going to be built equally. They have maybe differing solubility and then different palatability. So some of these are going to be more palatable to some patients than others based on what kind of salts they are. So how are they working essentially? Basically they will, you have things like sodium bicarbonate. Once they get mixed in with the hydrochloric acid that's being spit out by those parietal cells, basically gets turned into salt, water, and carbon dioxide. So based on that, what do you think is a possible side effect from this? Possible, maybe water retention, especially with like salt and things like that once it gets absorbed. What if that CO2 is being produced?
Oh, the gas.
Gas, yeah, absolutely. So you can see things like gas being produced, and they may have some eructation, as the fancy word for burping is. Right, so that could be one possible side effect there. You see calcium carbonate is on this list as well. We have aluminum hydroxide. We're going to see there's some particular issues with that with certain types of patients. And then you'll have magnesium hydroxide being on here. You're going to see that some of these will cause constipation, some of these are going to cause diarrhea, and so we'll actually see sometimes we'll actually mix two of them together in order to cancel this kind of things out. So we'll kind of get into those nuances as we go forward. But this is essentially the mechanism here. Pretty simple chemistry. So first one's sodium bicarbonate, otherwise baking soda. It's going to quickly neutralize the acid, but it's also going to produce a pretty high salt and alkali load, right? So this is where you can see fluid retention. After the sodium has been absorbed into the systemic circulation, water likes to go along with salt, so you see that. Produces gas as well, so that can have some burping and some abdominal cramping and things like that associated with it. And one of the big things you're going to see when you have these antacids is that when you neutralize all the acid, you raise the pH in the stomach, and so what does your body want to do to respond to that? Make more acid, right? Because it wants to maintain that homeostasis. So now you're kind of shifting things away from where its kind of normal set point is, and so it's going to want to increase the amount of acid spitting out to bring that pH back down, right? So you're going to see with the antacids, they're going to be somewhat self-limited by the fact that your stomach is going to want to kind of counteract that. Okay, that's where some of our other medications that work via different mechanisms can kind of deal with that, because they're working directly on either acid secretion or they'll be working on that kind of gastric barrier. Calcium carbonate is probably the most common one you're going to run into. Here's your Tums that you will frequently see, over the counter. You can get it very easily. Works very rapidly. It's good for, it has some more moderate neutralizing ability. And you'll see that obviously you're going to be absorbing some degree of calcium, so this could be problematic for patients who have, say, a history of kidney stones, especially if they have issues with hypercalcemia already related to kidney disease. We'll talk more about that when we get into kind of the renal issues. And then by increasing the pH of the kidney as well, by increasing that kind of the solute pH, you're more likely to have precipitation of that calcium there. So that's where you can see increased risk for kidney stones. Again, here you're also going to see increased risk for that rebound acid secretion, and then this one is going to frequently cause constipation. So calcium in general is always going to cause constipation, so let that be a warning for your patients. You may need to either use the drug less frequently, or you may need to adjust your dose so you don't have that big of an issue with it. Next, you have aluminum hydroxide. This one is not used too frequently. It's called Amphagel as its brand name. This one will be sometimes used for patients with really bad kidney disease because one of the other issues they run into is increased phosphate retention when you have poor kidney function. And so this is a drug that is sometimes used to bind up excess phosphate that get taken in through the diet. Does anyone know where you get a lot of phosphate in your diet from? Protein. So again, a lot of times they're recommended to limit their protein intake, but if you take this around mealtime, you would end up decreasing a lot of the phosphate you would end up intaking there. So that's where that drug normally is normally used, but you will see that aluminum hydroxide is co-formulated with things like magnesium hydroxide, and that's where you get things like your Malox and your Mylantas and whatnot. So you will still see aluminum hydroxide being used, usually not by itself though. Other big things this does is it's nice and cytoprotective effect on the mucosa, so it kind of has that barrier ability as well. Here you're going to see potential for constipation, and this will also chelate other drugs, so like fluoroquinolones and lots of these antacids can end up binding to lots of different drugs. So it's really recommended that you separate these out from other medications, right? So either take care of the medication, say like an hour before you use these antacids, or say maybe 2 hours afterwards, right? So that way you avoid any of the binding here. And then this aluminum can potentially cause issues with appendicitis, so this could be one to avoid for patients who maybe have active appendicitis or have a history of it. One of the other things to think about here as well is that patients who have poor kidney function are not able to process the aluminum that does get absorbed. So chronically, they actually found issues with those patients having neurotoxicity associated with the aluminum. And this was just basically, changes in mental status over time, neuropathies and paresthesias and things that happened due to aluminum buildup. So that's one thing to consider for your renally insufficient patients.
I'm sorry for making you go back. Contraindicated in appendicitis. Why is that?
I'm not sure why that is specifically. Just for whatever reason, it seems to be associated with that. Yeah, it's kind of one of those things that probably just came out of millions of people taking. They found that some increased risk there. So, okay. Mechanism-wise, I have no idea. The appendix does not like aluminum, perhaps. Next, you have magnesium hydroxide or milk of magnesia. This one has pretty good neutralizing ability. You will see that you will have some magnesium absorption, but you typically don't have to worry about your patients getting really a hypermagnesiemic from this because the mag chloride itself does not really get have a great solubility there. The other thing you'll see with this is diarrhea. So when we talk about things like laxatives, you'll see that this is frequently used by itself. So you guys ever seen those green bottles of milk of magnesia? Some people call them the green rockets because you take that and you're going to be going straight to the bathroom. So these are very, very good as a laxative, but again, that could be one of the big side effects. So this is why you normally see it co-formulated with the aluminum hydroxide because they kind of cancel each other out. The aluminum causing constipation, this one causing diarrhea, they kind of balance one another out. Other things you want to be watching out for is if your patient has renal failure, because again they can be more at risk for developing hypermagnesemia. This one can aggravate appendicitis, and then you can also run the risk of having intestinal obstruction. Basically, if things are kind of blocked up and you're trying to and you get something that has kind of these diarrheal properties, it can lead to some issues where things are just not moving. So if you have an intestinal obstruction, you don't want to give this one to make things worse. So as I mentioned here, magnesium hydroxide, aluminum hydroxide, this is your Maalox or Myolantas. So this is the common one you're going to see over the counter. This one will frequently be given in a liquid suspension, usually because a lot of the products themselves are insoluble by each one by themselves. And then there are some tablet formulations, but typically the liquids are a little bit better because when you're using them as an antacid, why do you think liquids would be better than tablets in this situation?
Liquids coat the stomach.
Yeah, so that kind of coating effect is real nice, especially with that aluminum hydroxide that's in there. We saw it had some kind of protective ability already, so if it can kind of, you see that like in the commercials, you see the liquid go down and it coats the whole stomach nicely. That's kind of the idea there. And so as I mentioned, you can use these together to counteract the GI motility. So either one by themselves can cause some GI distress, but used together, it's usually pretty neutral as far as diarrhea versus constipation. So some of the problems with antacids is that a lot of these are available over the counter. So that means patients can self-medicate, which means they can possibly be treating themselves and be worsening or kind of masking the worsening of disease, right? So especially if they have any kind of like peptic ulcer or something like that or something worse, if they keep treating the symptoms themselves, they may not realize they actually have an issue, okay? So maybe one of the things where, that's why they recommend on a lot of those directions on over-the-counter medications, only use for 2 weeks, right? It's not because the drug is any less effective or because it becomes dangerous after 2 weeks. It's just because if you're still having issues after 2 weeks, you probably need to get checked out to see if something else is going on, right? So that's why they usually have that kind of recommendation. You will see that most of these are going to be safe in pregnancy because, again, a lot of them do not have any kind of appreciable systemic absorption. So most of these are going to be kind of go-to for GERD symptoms for your pregnant patients. But you do want to avoid sodium bicarbonate. You guys think why?
She's already going to have edema being pregnant.
Right, so you're going to have kind of increased fluid volume. You worry about risk of hypertension as well, so that can potentially worsen that with the fluid overload. So that would be one thing to consider. Again, with the chelation here, with the drugs being bound up by a lot of these antacids, so tetracyclines, iron, fluoroquinolones, they can all be bound up by this, so you need to separate those out. Another one, alginic acid, is one that reacts with sodium bicarbonate, which is why you'll frequently see this in co-formulation with that, and also with saliva, and it provides this kind of nice viscous solution. So this one is, it doesn't have a ton of efficacy behind it, but it's been around forever, so a lot of people will still use this, and it's available over the counter. This is your Gaviscon, and so this kind of forms this nice kind of protective barrier that kind of helps the antacid to work as well. And so again, it requires the patient to be upright, because otherwise you can have some reflux of that. So I'd like to keep it in the stomach where it can be most effective there. Okay, so advantages to your antacid. So one, they have pretty rapid relief of symptoms. Again, because if you're having excess acid in the stomach, use it right there, neutralizes them, pretty quick action. They are relatively inexpensive, and they're available over the counter, so again, no prescription required for that. And these are going to be better used for breakthrough cases of GERD, right? So for instance, if you know you only have kind of intermittent symptoms and you can predict when those symptoms are going to occur, say for instance, I go to the Chinese buffet and I have the all-you-can-eat sushi, and I know I'm going to get GERD after that, this is a good time for antacids, right? Because I can predict that sort of thing. If it's more kind of chronic symptoms are happening kind of throughout the throughout the day, this is not going to be as good, right? Because we talk about that kind of rebound effect that you can see with that the acid secretion when you increase the pH in the stomach. Okay, so other things you will see with these drugs, they're not super effective for healing, which means if you have something like a gastric ulcer, these are not going to allow for enough time for the kind of conditions within the stomach to really kind of facilitate that healing, right? You're going to need kind of more potent agents that decrease acid secretion in order to help deal with that. Also, multiple dosing throughout the day is going to be needed for it to remain effective, and you also have the constipation, diarrhea issues as well to kind of compound on that. And then we talked about those drug interactions that can occur from the chelation here, right? So they're good for kind of just self-treatment for kind of intermittent symptoms, but you're going to see they're not going to be recommended for kind of around-the-clock therapy, and we have lots of other drugs that can be used for that, okay? So moving on, then we will have drugs that will reduce our gastric acid secretion directly before the acid's even been produced. We're going to block that from occurring. So we looked at this slide last time, so you guys should be at least familiar with that and some of the different substances that are going to have positive and negative effects on acid secretion. The first group we're going to talk about are H2 receptor antagonists, right? So we've already talked about H1 receptor antagonists. What are some examples of those?
Clarity.
Yep. Yes, that's the second generation. That's loratadine. Benadryl, diphenhydramine is a good one. Zyrtec is another good second generation. Cetirizine. It is, yep. Yeah. Meclazine's antivert, Good, so those are all good options as first generation antihistamines, right? Here, we're focusing on those H2 receptor antagonists, right? So there's not really any drugs that work on all histamine receptors. I like to keep some selectivity there. So these are H2 receptor antagonists. They're going to be working by blocking the actions of histamine to decrease acid secretion on these parietal cells. So these are good because they work kind of throughout the day, so they can block just basal release of acid. They block nocturnal release of acid, because sometimes patients will have GERD issues, especially at nighttime, and also stimulated acid secretion, right? So when you eat, your body is stimulating acid secretion. This will also be blocked by these H2 blockers. You'll see a reduced volume and hydrogen ion concentrations in the secretions, and can also help to reduce the amount of pepsin being released as well. Okay, so these are all good things for patients who are having your GERD symptoms, and are going to be kind of more potent and kind of more long-lasting duration of effects than you would see with the antacids. So we mentioned the ones that fall in this category. Many of these are available over the counter as well, because they've been around for a good long time. So you're going to see that they have kind of structural similarity to histamine, but they kind of have a bulky side chain that prevents histamine from kind of getting in there and interacting with the receptor. Big ones you'll see used with this are going to be cimetidine or Tagamet, ranitidine, famotidine, and nizatidine. One of these I'm going to recommend you never ever use. Can you guys guess which one?
Cimetidine.
Why cimetidine?
So many interactions.
Tons and tons of interactions, absolutely. So the cimetidine is a very potent PGP and CYP3A4 inhibitor. Don't ever use cimetidine. There's too many interactions there, and it's kind of a shame it's available over the counter, because patients can have easy access to that and take it without really knowing that they could be screwing up therapy with their statins, or they could be having issues with some of their calcium channel blockers, or lots of other drugs as well. So just be aware of that one as having kind of the most drug interactions out there. So our indications for this, so again, before the PPIs came about, these were kind of your go-to acid reducing drugs that were out there, and they could be used for peptic ulcer disease, GERD, Zollinger-Ellison syndrome, all kinds of different cases where you have hypersecretion of acid. All of them are going to be well absorbed from the GI tract. Most of these have IV formulations as well. So, for instance, ranitidine is probably the go-to H2 receptor antagonist IV-wise in the hospitals. Recently, we actually had a shortage. We had to switch over to famotidine. So, that's available IV as well. So, lots of different options for your patients. They are all going to be renally eliminated, so you do need to dose adjust for that one. And that's one I frequently see people not take into consideration, especially like, in the ICU, you have a septic patient, they're more at risk for having gastric ulcers due to that kind of hyper stress kind of state. And a lot of people don't adjust their H2 blockers for their renal function, so just be aware of that. As far as adverse effects go, they're pretty well tolerated for the most part. Some rare things you can potentially see, especially if you have patients with, say, poor renal function, they're getting kind of high doses. You may see some CNS changes. Usually not going to occur for most patients just taking this normally. And you can see some blood dyscrasias like thrombocytopenia associated with that. But for the most part, you're not going to see a ton of side effects with these. So these are going to be very effective in a majority of patients. Around 60% of patients should have some improvement in their symptoms, and you're going to see that it's going to be more effective and have a longer duration of action than your antacids, your alginic acid, or even placebo. Okay, so all good things. These are typically going to be cheaper than your proton pump inhibitors for the most part. So, if cost is going to be an issue, this might be a better starting option for a lot of your patients. But you may be making other choices on selection based on some of the pharmacokinetics of the drugs, but cost is usually one of the big ones there. They're all going to be more expensive than the antacids, but they are going to have a better duration of action. So some of these you can take, say, twice a day and have kind of all-day coverage, which is going to be good for your patient. These are also safe for use in pregnancy. All of them are category B. You'll see that the OTC doses, and this is kind of true for most drugs that are available over the counter, have a lower recommended dose or a lower dosage form than what you would see for like prescription strength. So keep in mind if your patient is like saying, I'm taking my ranitidine at home and it's really not working, they may not really be taking a full prescription type dose. So you need to kind of assess what kind of dose they're taking, and then you can still maximize their therapy to make sure they're getting a good amount to see really if that drug's going to work for them or not. So think about that, and remember, watch out for your elderly patients in the renal function. So these can either be used, kind of to pre-medicate. So again, if you think about duration or onset of action, which do you think are faster, the antacids or these drugs? Antacids, absolutely. So for instance, you can take an antacid along with your spicy food, and that will neutralize the excess acid, right? So that would work for that. With something like ranitidine, when should you take it prior to that meal? 30 minutes, an hour, something like that beforehand. So if you can predict it and you know when you're going to be eating in the future, then that's going to be useful. Otherwise, you can take these, just kind of chronically, take them daily, twice daily, whatever happens to be, in order to help prevent those symptoms of GERD from happening. So again, duration of onset of action is going to be longer than the antacids, but you can take these, throughout the day and get kind of all-day coverage. And again, watch out for famotidine, it's a CYP3A4 inhibitor. Just don't recommend that drug. Next, you have the proton pump inhibitors. So these are actually irreversible inhibitors of the proton pumps. We saw that the H2 blockers, they're going to be reversible inhibitors. They're going to, they're bind on the receptor and come off. These guys, once they bind to this proton pump, which you can see, right here, this is the proton pump we're going to be interacting with. When they inhibit that, it's irreversible. So once they're on the pump, that's it. And then your body has to generate new proton pumps in order to help start generating that acid again. So as far as potency for decreasing acid secretion, these guys are going to be king, right? So these are going to have the most potent effects on decreasing acid secretion. So after 7 days worth of therapy, once you've kind of started to saturate all those proton pumps, you have about 95% inhibition here, right? So these are going to be very, very potent for that. Some of the drugs we have available, we have things like esomeprazole, lansoprazole, pantoprazole. Obviously, you can tell the naming convention there to kind of recognize those. Which ones of these do you think are chemically related to one another? Yeah, so the omeprazole and esomeprazole. So that's one of those ones where you can kind of figure out the dose conversion pretty easily. To say something like 40 milligrams of omeprazole is equal to how many milligrams of esomeprazole? 20. Yeah, 20, right? Because again, with the omeprazole, 20 or 50% of that is going to be the esomeprazole. So again, it's pretty easy to make that conversion there. So always keep that in mind. You ever have to do like conversions for drugs on patients with these enantiomers. Yep, some of these are available IV as well. So something like pantoprazole is probably kind of your go-to IV proton pump inhibitor that I see used very frequently. Yeah, so these are great drugs. They're very, very potent, and these have kind of supplanted the H2 blockers in a lot of cases because they're so much more potent. So these are going to be indicated for patients who maybe have not been able to be controlled on H2 antagonists alone, and then for any other of these hypersecretory kind of states. Certainly you can use H2 blockers for healing of gastric ulcers and peptic ulcers and things like that, but these are going to be more potent for that because they have such a better effect for decreasing acid secretion. So you're going to see better healing in typically with the proton pump inhibitors than you do the H2 blockers. Some of the adverse effects, you can see there's some risk, or some people have some theoretical concern by blocking all these proton pumps. You have these hyperplasia of the parietal cells, so they wonder, if there's some kind of cancer risk, but clinically we haven't seen any real issue with that. More kind of a concrete issue that can pop up is one, we know we're going to have pretty sustained elevation of the stomach pH, right? So the pH is just going to be at a baseline higher level. So we worry about things like bacterial infections. And why do you think you can have a bacterial infection because of this? Yeah, absolutely. So normally bacteria do not like to grow in the stomach because it's very acidic and they normally can't survive there. So by increasing the pH, you allow a better environment for the bacteria to grow. And then what do you think is kind of the route for infection after that?
Gets into the ulcer.
Possibly maybe gets into the ulcer. What happens if I start to cough it up or if I throw up? Yeah, aspiration is the other big one. So that's a big concern we have for ICU patients. So imagine if you're an ICU patient, you're ventilated, you are, laid out there, you're going to be there for weeks, right? Say you have a really bad, say bacterial infection. You're in a super stressed state. Your cortisol levels are, off the charts. You're more at risk for developing gastric ulcers, right? So we know that's it's called a stress ulcer that can develop there. And so to treat that, you normally use something like a proton pump inhibitor, and it's very potent at blocking those acid secretions, so we use those drugs. The problem then you run into is increased risk for something like ventilator-acquired pneumonias because you've now made that bacteria a much more hospitable environment for it to grow, and it's able to have these micro aspirations into the respiratory tract, and you can see infection there. So that's kind of one of the double-edged swords we run into when using something like a proton pump inhibitor for these really sick, kind of at-risk patients. That's one thing you worry about. Also, by blocking all of these proton pumps, your body's going to try to respond by increasing acid secretion. It does that by having more gastrin, right? So that could be a potential risk you see there. Clinically, I don't know if that really comes out to be really an issue or not, but that is something they definitely see is increased levels of gastrin within the bloodstream. Yes?
With the increase in pH, does it slow the gastric motility at all? Like slow digestion?
Doesn't really slow down digestion that I've seen at all. I've not seen that issue pop up, but what do you think it does to absorption of certain electrolytes?
If it doesn't slow down digestion, then wouldn't it kill it? Because your body doesn't have time to break it down properly.
Break what down?
Protein.
Anything that you're eating.
So you still have some acid secretion, right? So you're still going to have some there. So you can still break down food. You don't really see any issues where they're not able to, because again, these are for patients that are kind of hypersecretory in the first place. So hopefully you're kind of bringing them back down to somewhere close to what, say, a healthy patient would have in the first place. So you really don't see any issues of like gastroparesis where they're throwing up like undigested food or things like that. You don't really run into that issue. The other big thing to watch out for is that calcium is not able to be absorbed as well if you're in a more alkaline environment. So chronically, you run into the risk of having hypocalcemia, which can increase your risk for what in, say, postmenopausal women. Osteoporosis, yeah. So that's a possible risk associated with that you want to be watching out for, is that patients who are on chronic proton pump inhibitors are more at risk for developing osteoporosis. So we may need additional calcium supplementation in order to help kind of go through that. And again, this is not one of those things where you could just separate when you give the proton pump inhibitor and when you give the calcium, because what's the duration of action for these proton pump inhibitors?
Indefinite.
Yeah, indefinite until you replace all those pumps, right? So it's going to be kind of a chronic effect that you're going to see with that, and that's why you see that effect being much more pronounced with these guys than you would with H2 antagonists. Okay, so again, these are also good for pregnant patients, so certainly get away with something like, lansoprazole or rabeprazole. These are all going to be pretty safe for your patients. But typically, kind of go with a stepwise approach for those pregnant patients, where you kind of use the kind of least systemic exposure as you can. So an antacid might be a good option. If they don't tolerate that, then H2 or PPI is probably safe in those patients.
From one of our GI lectures, she has under side effects for PPIs. May elevate levels of plasma dimethylarginine asymmetrically, and then increased risk of cardiovascular disease.
Just a theory.
I don't know. Yeah, I'm not.
Like possibly.
It could be something. Yeah. So I mean, these are given to a lot of patients. So this would be one of those things where if it were to pop up, like it's probably a very small incidence of it, and I'm not aware of that being like shown out there in the clinical literature. But not to say that it's not out there. There's lots of things I haven't seen. Yeah. So it could be a potential risk there, but news to me. Okay, so these proton pump inhibitors, these should be administered 30 minutes prior to meals. Why do you think that is? They take longer to work? Why is it? Yeah, so the thing here is that they're only going to work on actively secreting pumps. Okay, so when are your pumps most actively secreting? Right before you eat, right? So this is why you give it right beforehand, because you're more likely to hit as many of those active pumps as possible, and so you're going to get a better kind of quotient of those pumps being inhibited. So that's kind of the reason why you give it before meals.
But I thought we had like steady state going on and all the pumps are 95% of the pumps are blocked in.
Yeah, once you get to that steady state point, but again, by taking it 30 minutes before meals, you're more likely to get those new pumps that are being generated and them in the active state, and then you can inhibit those too, right? So you just get a higher fraction of those that are available to be blocked before you eat. Yep. So do not crush or chew these products. Many of them come in a capsule, and you'll see there's like lots of little different beads that are within the capsule themselves. And so those are actually pH dependent solubility of those little pellets, essentially. So the idea is that the products will not degrade when they're in an acidic environment, and then they will then dissolve once they get into a more basic environment. So the idea here is if you put the drug by itself, the PPIs, into the stomach, if you were to say crush or chew one of those capsules up, it's going to just break the drug down and it's not going to work. Okay, so by passing it through the stomach where it has that kind of protective layer on it, and then it gets into the duodenum where it is more basic, it'll dissolve that coating and then the drug can be absorbed. Okay, so that's the reason why we don't crush or chew these products, is because of that. And actually for kids, when we have to use liquid formulations, we have to compound it ourselves because it's kind of unstable just inherently when you break that down. But basically you mix sodium bicarbonate with these, with the drugs, in order to dissolve it, and then they take that orally. Probably some less activity there because it's hitting the stomach, but the idea is, kids can't really take capsules all that well in a lot of cases. So, okay. Typically, if you have severe esophagitis or just need kind of better symptom relief, PPIs are going to be a little bit more potent, but again, they're probably going to be a little bit more expensive. Adverse effects wise, nothing really too big to note here. These are very well tolerated as well. Some drug interactions, you may worry about certain absorption of drugs, things like ketoconazole or itraconazole, but for the most part, you don't see a lot of issues there. But you can see decreased absorption of certain drugs, especially calcium as well, because you're kind of monkeying around the pH in the stomach. So, I think there are some other OTC that are available now, but at least omeprazole is the first one to go over the counter. So again, this is there's always a potential risk when patients are self-medicating, and this is why patients need to be educated if they're using these products over the counter when they should be coming back to you for a better workup, right? So certainly, kind of those warning symptoms that you always kind of warn patients about. So if they have say black tarry stool, what are you concerned with? Yeah, upper GI bleed, so any kind of blood they're seeing, or if they're having trouble or pain swallowing, that could be a big warning sign that they should not be self-treating with. Obviously, any kind of hematemesis would be a problematic as well. And then one of these things they're seeing is that, certainly have them consult, if they're having any of these kind of other warning signs. It could be indicative of other problems that the PPIs are not really going to be sufficient to treat on their own. Okay. So a lot of these you'll see used in kids regardless, but most of the FDA approvals have been made for patients who are 18 years or older. And again, this is when you should discontinue the OTC use. Again, if they're still having kind of protracted symptoms even after kind of the recommended time frame there, they need to come get checked out just to make sure there's nothing else more serious going on. So next we have one gastrin inhibitor. So this is going to be octreotide. There's actually one other interesting use for this that we use in the tox world I'll mention. But basically, it kind of is an analog of somatostatin, which is an endogenous product that your body makes. It will block gastrin release. So you can see this used for gastrinomas, Zollinger-Ellison, any of these kind of significant hypersecretory conditions. I also see this used sometimes for severe diarrhea. And this is actually a parenteral only agent. The place where we use this in the tox world is this will actually help block release of insulin from the pancreas, and so we'll use this for sulfonylurea overdoses. So if a patient takes their glipizide, takes too much of it, or a kid gets into glipizide or something, this actually will block insulin secretion, and it'll help kind of stabilize their blood glucose. That's one place you might see it being used, other than just for strictly a GI issue. Sometimes I also see this used if they're having patients having like variceal bleeds. Sometimes they'll be put on an octreotide drip for that as well. Okay, so those are our acid reduction drugs that we have there. Next we'll have the mucosal protecting agents. So one of the big ones here is going to be colloidal bismuth, otherwise known as Pepto-Bismol, usually marketed as bismuth subsalicylate. This is good because it helps to coat the stomach, enhances a lot of the cytoprotective features of the gastric barrier already, also will inhibit things like pepsin activity. Do note that this can impart a black color to the feces, so in the tongue as well, so they need to be warned about that so they're not thinking there's some other big problem occurring there. And then what kind of patients do you think this would be contraindicated in?
Post-viral syndrome.
Yeah, so kids less than 16, post-viral, because you worry about? Ray's syndrome, yep. Very good. You also have carafate or sucralfate. This is an aluminum salt, and it's non-absorbable, which is good, so you don't really have any kind of systemic absorption of this one. But essentially what happens is the carafate kind of mixes with acid. It turns into this nice kind of thick paste that will sit there and protect the stomach. So usually recommended for more mild cases of GERD. We use this very frequently in a lot of kids, especially those that are having, if they can't really take, they don't want to give them an H2 blocker. This is a nice one because it just kind of helps protect the stomach a little bit better than nothing at all. So you'll see this one being used somewhat frequently in kids. So another group we'll talk about as kind of enhancing the mucus barrier there is going to be some of our prostaglandins. So we can use things like misoprostol, which is a PGE1 analog, otherwise known as Cytotec. That's probably going to be the main one. Sometimes you'll actually see this mixed in with an NSAID, and so that can be used sometimes for kind of additional protection if you need to use an NSAID, but they have risk for ulcers developing. Basically, it works on that prostaglandin receptor to increase mucus production and decrease acid production. And so frequently you'll see this used for patients who have NSAID-induced ulcers to kind of help facilitate, because again, NSAIDs do what to prostaglandins? Yeah, to prevent them from being made in the first place, right? Because you're blocking cyclooxygenase, so you prevent the prostaglandins from being made in the first place. Now we're just going to give a replacement for that. This is definitely contraindicated in pregnancy. This is actually a drug that will sometimes see used for like chemical abortions, essentially. Something like this mixed with like methotrexate can be used. And so actually it's kind of interesting, just like we were talking about with having, working at a hospital with religious affiliations. I actually interned when I was in school at St. Vincent's up in Jacksonville, and it was a Catholic-based institution, and so they actually never even stocked misoprostol because of this risk of someone using it for this kind of abortion effect, and so they actually just didn't carry the drug, which is kind of interesting to see how some of that interplay can occur there. So anyway, but more often than not, you'll see it being used for the mucus protection agent.
You said it would be mixed with NSAIDs. Why would it be mixed with NSAIDs if the NSAIDs are causing the ulcers?
So if they had, this is before like you had more COX-2 selective blockers, right? So this was the case where if you had a patient who had chronic pain and you needed to treat them with an NSAID, giving them the misoprostol was kind of just a kind of prophylactic, right? So it's kind of like, we know this is going to cause the side effects. Let's give you another drug to go ahead and treat that, right? Because 2 drugs are always better than 1. Just so you know. Just kidding. Okay, so looking at comparative efficacy for GERD symptoms, cost is obviously going to be the lowest with your antacids and just kind of go up from there. Obviously, compare your onset of relief. Obviously, the antacids are going to be the quickest in that regard. And also look at the duration of relief, so antacids are going to be the worst at that because they are only going to be sticking around for a short period of time until that neutralization is done, and then it's gone. So just kind of keep the general comparisons in mind. You don't have to know the exact numbers, but be able to, say, I have a patient who comes into the clinic and they are only having symptoms when they go and they eat really spicy curry and they have no health insurance. Like, what's going to be the best option for them? Don't eat the curry, no. But they love their curry. I have to get it every week. Yeah, an antacid is probably going to be the best option for them, right? Versus someone who has, say, symptoms every single morning of GERD. They have to teach it, 8 o'clock in the morning twice a week, and he has really bad GERD symptoms, right before then. Just kidding. So if it's more consistent, then that's something like an H2 blocker or PPI is going to be better for that, right? So just keep in mind the kind of symptom, kind of the chronicity of it, how intermittent it might be, and that kind of guides you in picking your therapy there. Yes?
For efficacy, is fair below good or above good?
I don't know, what do you think? Probably shouldn't use two different adjectives for that, right? Fair is probably less than good. Okay. Yeah. It's a fair weather gastric protectant. Yeah, Carafate not super great for if you're having like legitimate like GERD concerns. Like Carafate's not going to be good. This is more for, I see it a lot in like a lot of our hemonc patients who are kind of receiving a lot of like chronic meds and a lot of meds that are not real easy on the stomach. Just use kind of an additional kind of protectant.
Who's the worst?
Probably the worst. Yeah, I would not recommend that specifically for GERD symptoms. Right, I'd usually use that in conjunction with other stuff.
What about misoprostol? How good is that at reducing acid?
It's not really. It's okay at reducing the acid, but it's more that protectant, the barrier protection that you're using it for. Again, I would not often recommend that unless the patient really had no other. Because again, it's an older drug, and it wasn't really. It was used before you had a lot of like PPIs and stuff that were available. And again, you'll sometimes see it mixed with an NSAID. I think it's Arthurotec. I believe it's diclofenac it's mixed with. I could be wrong though. But basically, it was back when they really had no good way to give NSAIDs to patients who had a history of ulcers. That's where you use it as that protecting agent. Yep. Any other questions on it? Yeah, Celebrex is the way to go now. Okay. So essentially when we're doing this, again, you kind of go through phases of treatment. Again, we kind of talked about some of these points here, but obviously as symptom severity gets worse, you can kind of step up your therapy from there. So they're having severe kind of all the time GERD symptoms, go with the PPI. Like use something that's going to really be effective and really knock things out. And, potentially for more intermittent breakthrough symptoms, something like an antacid is going to be good for them in that regard. So obviously lifestyle changes are going to be good too. So tell them not to eat the curry, but lifestyle changes can be plus or minus for depending on how motivated your patient is. But again, if it's just intermittent mild heartburn, antacids are good. Step up from there. You're going to need more kind of chronic therapy with the H2 blocker or PPI. If you're having patients who are having like severe ulcers that need healing, we'll talk more about that a little bit later. PPIs are probably going to be a better option for that because they have quicker heal times, just because they're more potent at blocking acid secretion. And then sometimes you need interventional therapies. Obviously with kids, they have the it's the Nissen procedure. Basically, if they have like kind of a lower esophageal kind of low tone for that, they can do the procedure that actually will bring up part of the fundus of the stomach over the lower esophagus. So there's procedures that are available for that. But usually, once they've kind of failed many other things, that's when you kind of go with the surgical interventions. So. Most patients end up relapsing, so some patients may need more chronic therapy, but this is kind of one of those things where things get better and then they stop taking their medications and then they may need to go back to it. But most patients do require some standard dosing for more kind of consistent care for that, so just keep that in mind. All right, any questions from the first half?
No, they're pretty good.
Nothing at all. Okay, so we're going to continue on with our treatment for peptic ulcer disease. You'll see a lot of the same drugs popping up again, so it's just about how we're using them specifically. So main thing we're going to be mentioning here is going to be H. pylori associated ulcers. We're going to see how to treat that. We're going to have our NSAID induced ulcers as well. Obviously we're going to have a pretty good way to treat that. And then we'll have some stress related mucosal damage and how we can treat that. All of these are going to lead to symptoms of dyspepsia. So we'll see what kind of medications we can use. And I heard there's an OSCE associated with this tomorrow. So maybe this might be useful to you guys. So we'll see. Hopefully not. I'm just kidding. Okay, so as we mentioned, when you're having gastric acid secretion, this hypersecretion, a lot of times you can end up developing duodenal ulcers. You can also have normal secretion in gastric ulcers, and also with non-ulcer dyspepsia. A lot of it has to do with, what is, that kind of protective barrier looking like. So if I had something like chronic NSAID use with a non-selective NSAID, even if I have normal secretion of gastric acid, if I'm kind of decreasing that barrier, you're more likely to develop this kind of gastric ulcers there, right? We know pepsin is important here because it is important for digesting proteins and stimulating acid secretion. And then again, like I mentioned, that mucosal defense, if this is being interrupted, you're more likely to see these gastric ulcers. So what are some of the risk factors? We know H. pylori infection. Have you guys ever heard of this story for how they discovered H. pylori? It's pretty cool if you ever go out there, and there's some good YouTube videos. Basically, there's an Australian scientist who, or a physician who had this, hypothesis that H. pylori is causing all these ulcers, and so no one believed him, and so he decided to go ahead and drink a whole bunch of it, ended up getting a really bad ulcer, and then took antibiotics and cleared the ulcer, and so then he got like a Nobel Prize for it eventually once they were able to kind of replicate his findings. But it's one way to do science. Anywho. Yeah, take one for society. So go watch some videos on that. It's pretty interesting. So NSAID use is going to be one of the biggest influences for peptic ulcer disease, especially with gastric ulcers. Certainly other things like smoking, stress, and some genetic predispositions can make you more prone to this as well. So some treatment considerations. So how you treat these ulcers is going to be very dependent on the etiology of it. So the cause of the ulcer, so whether it's H. pylori or NSAID induced, whether this is an initial ulcer or whether this is kind of a recurrent issue, and then whether any complications have occurred, right? So obviously with complications, we may need kind of more severe therapy in order to help deal with that. For conventional therapy, you're going to find that most ulcers heal in a period of, say, 4 to 8 weeks or so. Looking at PPIs versus H2 blockers, which one do you think works faster? PPIs are going to be faster, right? So typically treatment times are shorter with PPI-based therapy than you see with H2 blockers. Typically, you see that the gastric ulcers are going to be larger and more difficult to heal than the duodenal ulcers. Because again, usually the duodenal ulcers are just related more to hypersecretion, and this is pretty easy to deal with, versus if it's more of an issue of the actual barrier being disrupted. Most H. pylori positive patients end up relapsing within a year with conventional therapy only. This means this is why we use our antibiotics to help make sure we eradicate that infection, so that way it doesn't come back. So, some non-pharmacologic therapies you could always consider if we can eliminate or reduce the psychological stress, right? So like getting through Pharm 2 and then you have that stress gone, you have to worry about your ulcers coming back. Avoid certain trigger foods, so smaller, more frequent meals can help with this. And then as far as NSAIDs go, either avoid them altogether, decrease the dose of the NSAID, or if we could potentially say switch over to what type of NSAID? COX-2 selective, right? Which is? Celebrex or celecoxib. That's another good option. And then obviously ethanol, smoking cessation are going to be big helps with this as well. So how do we treat this? Well, all the same drugs we've already seen, so we'll kind of go over those again, and then we'll also look at drugs we use specifically to eradicate H. pylori. So we'll get into some antibiotics, something I know you guys have been missing for a while, so I wanted to kind of bring that back up again. So as far as efficacy goes for our H2 receptor antagonist, you see that the healing rate is pretty good, anywhere between 70 and 95% after 4 to 8 weeks of therapy. More effective than antacids, and that makes sense based on the duration of action of these drugs, how they're going to be working more consistently throughout the day. And all of the agents are going to be equally effective, so not one H2 blocker works better than another. It just depends on what, say, on formulary or what's the insurance covers, whatever happens to be. They're going to be much cheaper than PPIs and other forms of therapy, effective in most cases. And then, like I mentioned, we have IV and liquid formulations available as well. So those are going to be, say if you potentially had say a bleeding ulcer or something like that, and you had to treat them inpatient, we have IV formulations. Sometimes people will be placed on drips of these medications. So sometimes you'll see that for really bad, say if you have like a GI perforation or something, you can certainly be placed on a continuous like H2 receptor antagonist drip or like a PPI drip. So that may be something you'll see out there in the clinical world. So again, as far as efficacy goes for the proton pump inhibitors, symptom relief and healing can occur in just 2 to 4 weeks. But absolute healing rate, so the actual number of people who end up being healed after full therapy, is pretty similar to the H2 receptor antagonist. But again, most patients probably want quicker healing in general. So that's probably going to be the preferred agent if the patient can afford it and if it's feasible. All these are going to be equally effective as well. All of them are going to work very similarly. So antacids usually should just be taken for more kind of as needed kind of breakthrough symptoms. And again, we've talked about all the different varieties that are out there. Again, look at the comorbidities of the patient. Do they have renal disease? Do they already have history of nephrolithiasis? Do they have kidney stones? Do they have all these other issues? And it might guide you in selecting one antacid over another. And remember those drug interactions with that chelation effect you see there. So as far as H. pylori goes, how are we going to treat this? Well, we know it's a gram-negative bacteria, so that's going to be informing a lot of the different types of antibiotics we can use here. We know that it's one of the most common causes of non-NSAID ulcers. Again, go back and watch these videos of the Australian physician. The thing here is that it's going to be surviving in an acidic environment of the stomach. It does this by producing this urease enzyme, which is important for diagnostic testing because you can do what?
Urease breath test.
Yeah, do a urease breath test. So basically hydrolyzes urea within the gastric fluid and it converts it to ammonia and carbon dioxide, and that kind of allows for this kind of local buffering environment. That's what allows the H. pylori to kind of thrive in an otherwise acidic environment. So again, we said this is going to be most non-NSAID induced ulcers are going to be infected with H. pylori, and so by eliminating the bacteria, we're going to help to eliminate the recurrence of disease. And so a lot of people probably have asymptomatic infections, and depending on where you're at, you can see 50% of the world's population end up having H. pylori to some degree. The big thing you also consider is the carcinogenic risk. So by eradicating these infections, you also kind of eliminate that risk as well. And we know that the damage this is doing is due to a couple of different mechanisms. One is due to direct irritation of the gastric epithelium. It also can alter some of the host inflammatory responses. And then you can see a secondary kind of hypergastrinemia leading to increased acid secretion. So, by kind of inhibiting that barrier and then kind of increasing the pH, you cause increased acid secretion, which kind of damages other areas in the stomach as well. So, how do we treat this? Well, it's going to be with a combination of medications. So again, here's one of the few places where more drugs is better. Antibiotics are going to be important here, and some of the antibiotics that will have activity against H. pylori include things like clarithromycin. We'll have amoxicillin, metronidazole, and then tetracycline as well, right? So for instance, say if you had a younger patient, say someone you were treating that's say 7 years old, you're worried about H. pylori, which one of these do you think you'd want to avoid? Yeah, I remember tetracycline. Why is that? The teeth staining, right? Teeth staining, bone staining, you can see there, so you want to avoid that. Also, pregnant patients, you probably want to avoid that as well, especially kind of later term pregnancies. So remember those little key points about the antibiotics we mentioned there. These are the main ones you're going to end up using for the most part, especially with non-resistant H. pylori cases. Other things we're going to use include ranitidine, bismuth citrate. There's actually kind of a Tritec pack you can see there. So bismuth is going to be the other kind of big component to that. So bismuth subsalicylate, you can either use Pepto-Bismol kind of separately, or some of these will include multiple drugs together in order to help treat this. So what do you think the bismuth is doing in this case? Kind of just helps coat the stomach, kind of helps to kind of provide kind of a supplement to that gastric barrier here to allow for that ulcer to heal a little bit better. And again, H2 receptor antagonists or PPIs are going to be used in this case. You don't necessarily need to use both. One or the other is going to be fine. So again, bismuth preparations help with that local gastroprotection. They'll also help to stimulate kind of endogenous prostaglandins, and they actually help to suppress H. pylori. So kind of multiple mechanisms here for the bismuth helping. Like I mentioned, there's multiple different products that are out there that will combine different drugs together, but certainly Pepto-Bismol can even be used by itself, right? What are some of the advantages of these kind of combination products?
Compliance.
Yeah, compliance, fewer pills to take, so that's kind of one of the big things why you see multiples of these put together. So for instance, the Helidac has the metronidazole, tetracycline, and bismuth all together in one product, and so it just helps to increase compliance for your patients. So there are a couple of different types of regimens. We don't recommend 2-drug regimens anymore because we found that the recurrence rate was too high, the efficacy was not good enough. So you either have a 3-drug or 4-drug regimen, but typically you can get away with recommending the 4-drug regimen. You're more likely to see actual eradication of the infection with that, but better success rates. Notice how the duration here can be a little bit shorter for the 4-drug regimen, and as I mentioned, the efficacy is going to be a little bit better. So for most patients, this is going to be the best way to go for them, especially if you have an initial infection, just to get rid of it, and hopefully they don't have any relapses there. So what are those regimens? So for like a 3-drug regimen, usually it's going to include at least 2 antibiotics and then some sort of gastroprotectant agent. So in the 3-drug regimen, you see something like clarithromycin plus amoxicillin and then a PPI. Right. With the 4-drug regimen, this is where you're adding on typically the bismuth in order to get additional protective features. Okay, so that's really the big difference there. So for instance, in a 4-drug regimen, you may see metronidazole plus tetracycline. Okay, the actual combination of the antibiotics doesn't matter so much, especially when you start to get to treatment failures and you're looking to see, well, do we have a resistant H. pylori? You may see that they're resistant to metronidazole, so maybe you use clarithromycin and tetracycline. Right, but by using the 2 different mechanisms with these antibiotics, you're getting some synergy there to help eradicate that infection. So again, for example, like with some of the studies they've done, they found that if you fail therapy, other than just doing the resistance testing, it appears that amoxicillin and metronidazole might be a good combination to go with as kind of a secondary.
Would you submit gastric secretions for culture to find out what that H. pylori is?
I don't know specifically how they go about getting those samples. I do not know.
You'd use an EGD?
That's what I was thinking. Yeah, like an EGD, and like do kind of a swab of one of the ulcers, something like that.
NG2 would probably be it'd be much simpler.
Yeah, ask your local gastroenterologist. They would probably be much more knowledgeable on that. I just look at the results and they come back and say, oh, that's resistant, let's not use that. Okay, again, you're going to be choosing your regimen primarily based on tolerability and the allergies of the patient. So if they have like a penicillin allergy, you probably want to go with something else other than penicillin, right? Look at your drug interactions, if there's any issues there. Cost can be important here, so especially if some of the combination products are brand only and they have more costs associated with them, you may be better off just prescribing the individual agents and having them taken together. More pills to take, but if the patient can't afford it, they're obviously not going to take it. And then, like I said, antibiotic resistance. For the most part, you can probably treat most patients assuming no resistance, but they fail therapy. If the ulcer is not really getting any better, if they relapse, that's when you want to consider doing that resistance testing. So we already kind of mentioned this, but if initial treatment failure, use different antibiotics than what you did initially. If you're only using a 3-drug regimen, bump it up to a 4-drug and use the bismuth there, and treat for a longer duration of time. So say 10 to 14 days instead of that 7. So that's it for H. pylori, so pretty straightforward. With the NSAID-induced ulcers, we know that the big risk factors include obviously using non-selective NSAIDs there, but other things include a history of peptic ulcer disease or any kind of GI bleeds, age greater than 60, concurrent corticosteroids. This is actually a big one, especially if you were looking at like, say, more critically ill patients who are on corticosteroids, or patients who have, say, like, I guess what's another condition where you might be on daily steroids? Yep, so a lot of autoimmune conditions. Think of any other ones?
Asthma?
Usually not asthma. Usually it's more of like an inhale. You don't want to be like an oral therapy chronically. Like rheumatoid arthritis is probably a big one, where you might see kind of chronic daily use of corticosteroids. So all of that can help to decrease because again, corticosteroids do what to prostaglandins? They shut them down, right? Because they work even higher up in the arachidonic acid cascade than the NSAIDs even do. So of course they're going to decrease prostaglandin production and decrease that gastric barrier. So again, that can be another big source here. So kind of mixing a corticosteroid plus an NSAID, which you might oftentimes see in rheumatoid arthritis, can be kind of a double insult to the stomach. Using high doses or multiple NSAIDs here can be a problem. Concurrent use of anticoagulants, why do you think that's an issue?
Bleeding risk?
Yeah, more risk for bleeding, right? So a patient on warfarin who has an ulcer, more likely to bleed than one that was not on warfarin, right? And then any kind of like major organ impairment, so cardiovascular disease seems to increase your risk as well. So for the pathophysiology, so we kind of already alluded to this, but again, this is going to be due to topical direct irritation of the gastric epithelium by inhibiting the COX-1, which we know that's the constitutive cyclooxygenase that helps prevent that synthesis of the GI mucosal prostaglandin, right? So by inhibiting that, you cannot produce that barrier, and so you're going to have direct acid working on the epithelia to damage that. Usually you're going to see that the ulcers don't necessarily correlate well with the absence or presence of pain, right? Because usually like one of the things like, say for instance, with like a duodenal ulcer, what are kind of how does the pain change? I guess, or what makes it worse or better?
Food makes it better.
Yeah, food makes it better, because what does that do to the duodenum? Well, it increases the pH, right? Because you're helping to neutralize all of those gastric acids, right? So because this is strictly in the stomach and because it's due to kind of this more chronic irritation due to the NSAIDs, you're not really going to see any good correlation like that. So it could be just kind of chronic consistent pain, or it could be a little bit more inconsistent. So again, if you were to compare looking at H. pylori versus NSAID-induced ulcers, you're typically going to see that the H. pylori is going to be more duodenal ulcers versus gastric, versus the exact opposite with an NSAID-induced ulcer. You're going to see the NSAIDs are going to be less pH dependent, because it's not really going to matter so much, because it's more due to disrupting that barrier. A lot of times the NSAID-induced ulcers can be asymptomatic, so you don't really notice anything's wrong until they start to develop, black tarry stool, and they have an upper GI bleed. Typically see deeper ulcerations with these, and they're more likely to see life-threatening severe bleeds with the NSAID-induced ulcers, right? So typically much more dangerous, just because they're a little bit more clinically asymptomatic and kind of don't present until they're kind of far along in the process. So how do we treat them? What's the number one step in therapy? Stop the NSAID. Yeah, it should be pretty common sense there. So if possible, stop the NSAID. If not possible, that's when you need to consider switching agents. So maybe something like a more selective COX-2 inhibitor, like we mentioned, celecoxib, or acetaminophen might be a better option for them. You also want to evaluate at that time for concurrent H. pylori infection and treat if it's present. And then at that point, we can consider using our acid reducers, so your PPIs, H2 blockers, plus some sort of gastroprotectant like sucralfate. PPIs are going to be preferred here, right, because they're going to be more potent at knocking down that acid secretion, so they're going to be better at helping to get rid of that acid and allow the ulcer to kind of just heal on its own. Notice how the duration here is going to be shorter for PPIs as well, so at least 4 weeks for them. H2 blockers maybe 6 to 8 weeks. You may need, for patients with larger ulcers, may need higher doses or longer durations of therapy, but you're kind of doing it on an individual basis at that point. So to prevent the ulcers from occurring, patients who have a history of NSAID-induced ulcer who have to continue. Again, we know the ones that are going to be a higher risk. What do we do for them? We can potentially use kind of protective or kind of prophylactic therapy in some cases for them. So this is where we can use something like misoprostol. Can be a good option here potentially. So cytotec. Again, like we mentioned, it's a prostaglandin, so it kind of helps to replace what you're inhibiting by giving an NSAID. Probably your better option is use a COX-2 selective one, and then also use something like a PPI along with this. Yeah, so you see that Arthrotec there, that's a misoprostol plus a diclofenac. So kind of using a prophylactic agent along with the non-selective NSAID. Okay, once you kind of have the healed ulcer, how do you kind of maintain that? You typically don't need maintenance therapy, but you may want to consider this if they have a history of kind of frequent ulcer recurrences, they have a history of ulcer-related bleeding or other complications, so kind of the more severe ones, you may want to consider more prophylactic kind of maintenance therapy, and then those high-risk patients. And if they have, if they failed HP eradication therapy, you may need, while you're kind of getting resistance testing back, you may need some more maintenance therapy to help kind of maintain their symptoms. So if NSAIDs are going to be discontinued or after the eradication, how would you maintain those healed ulcers? Again, either low-dose H2 blockers, PPIs, carafate, any of those are going to be fine for helping to maintain remission of those symptoms. And again, if NSAIDs have to be continued, that's where you need to consider PPI or something like misoprostol. Okay, so any questions on ulcers? Okay, moving on to antiemetics. So what are indications for antiemetics? Well, probably anytime you feel like you're going to throw up, right? So severe nausea, vomiting, we'll see this used for a lot of these drugs for motion sickness. A lot of cases, post-operative nausea and vomiting can be a big thing. And then also nausea, vomiting associated with chemotherapy. Now, which one of these out of the group do you think is probably the most severe nausea and vomiting? Chemo, yeah, absolutely. And it's going to depend on the chemo drug. A lot of places, if you deal with chemo ever, you're going to see they have antiemetic guidelines, and you'll see they have a list of drugs that are low to high emetogenic risk. Does anyone think of any really high emetogenic risk drugs? Probably like cisplatin is probably one of the big ones. This is probably one of the more severe nausea and vomiting inducing drugs that are out there. But just keep that in mind that a lot of you'll have just a whole barrage of medications to give those patients because the nausea and vomiting is so severe with those drugs. And so that'll be one of the big places you see a lot of them being used concurrently. So how does a lot of the signal for nausea and vomiting develop? Well, we have the vomiting center in the medulla. We also have a lot of chemoreceptor, we have the chemoreceptor trigger zones located in the fourth ventricle. And then there's a lot of kind of complex interactions here with a lot of the nerves going into and out of the GI tract. So specifically like on the stomach, see there's serotonin receptors that are there. That's where some of our serotonin blockers are going to be working. But it's also important to note a lot of other receptors that are important for this. So for instance, if you're looking at the chemoreceptor trigger zone, you're going to see that serotonin is important here. You also have dopamine receptors, so D2 receptors, which what type of drugs would inhibit that? What kind of dopamine blockers did we just talk about? Or antipsychotics, right? Yes, antipsychotics will do this as well. So that's why a lot of them have kind of good antiemetic properties. You also see that the muscarinic receptors are going to be involved here as well. So things that have anti-muscarinic activities typically will limit nausea and vomiting. Okay, so we already see several sites for where our drugs can be working, right? So we'll see dopamine, muscarinic receptors, serotonin, all are going to come back in the different mechanisms that we can use to treat nausea and vomiting. So the first group we'll talk about are going to be our antimuscarinic and antihistamines. Some of the ones that they're included in just the antimuscarinic group include scopolamine. Scopolamine typically comes as a patch you will apply. This one only has antimuscarinic activity, and so this one is applied usually every 3 days or so, so it has a nice duration of action. Where do you normally see scopolamine patches being used? Where are they often recommended? Cruise ships, okay. So when do you tell the patient to start using it?
2 days before they go.
Yeah, a couple of days before they actually go on it, because if they do it right as they're walking on the boat, it's not going to work, right? Because we said transdermal patches take time for the drug to diffuse across the skin, so they need time to work, okay? And so what do you think happened with this person right here? So they're having a head bleed. Get them to CT immediately. No?
Why do they have anesthesia? Why is it different?
Yeah, why is it different?
Because
What happens if you have, yes, that's not syphilis. What happens if you have an antimuscarinic effect in the eye? Yep, you're blind as a bat, right? Do you get mydriatic or do you get myotic? Mydriatic, right? So this person's having kind of unilateral mydriasis in one eye, and we're talking about an antimuscarinic drug, so especially a patch, it's transdermal. What do you think happened?
It's in there.
They probably didn't wash their hands real good after this, right? So they probably were applying the patch and then rubbed their eye, and then that's what, right? So this is actually from an interesting case report where a person comes in like this, and if you see a person like this, like your initial thought is probably like some sort of like, head bleed or something. Like, oh no, we need to, expecting slurring speech and all kinds of other bad stuff. But no, this person just didn't wash their hands good after using the drug. So again, may have some kind of blurry vision out of the one eye, but that's why I just recommend have them wash their hands real good. So, but again, you'll see this most often recommended for motion sickness, so cruise ships and things like that, and expect to see all the normal antimuscarinic activity because again, it's going to be working peripherally just as much as it does centrally. So you can see dry mouth, blurry vision, urinary retention, all that stuff goes along with that. And you guys remember the mnemonic, so mad as a hatter, blind as a bat, all that stuff still applies to this drug here. Okay. Other drugs that you can use that are typically used more in the oral route, most frequently for nausea and vomiting. These are going to be antimuscarinics and antihistamine actions these drugs have. So this is where you see like your dimenhydrinate or Dramamine, your meclizine or antivert, hydroxyzine is another big one, and then diphenhydramine. So these guys are going to have antihistamine and antimuscarinic activity. Right, and these are good for things like vertigo as well. So frequently you'll see like meclizine being used for patients with vertigo coming in. That's where they get a lot of their use. Big side effects you see with these drugs because they have antihistamine and antimuscarinic actions. It's going to be sedation, right? So anytime, just like you've taken Benadryl before, I'm sure, it's going to knock you out to some degree. Same thing would be seen with these guys. All of them are going to be tolerated pretty similarly, and they all work very similar to one another. So it doesn't really matter if I use one versus the other because they all work very much the same. Okay, so then moving on, we'll have some anti-serotonergic drugs as well. So by blocking the 5-HT3 receptors, we're going to be able to inhibit both activities in the chemoreceptor trigger zone, also in the GI tract itself. So this is where we get our ondansetron, our dolasetron, and granisetron. I will tell you probably ondansetron is the one that gets the lion's share of use out there in the real world. I see granisetron really only being used for patients who are refractory to that, usually with our chemo patients. So sometimes if they're not really tolerating the ondansetron very well, they're still having a lot of breakthrough nausea and vomiting, this Chitrol will be used as kind of a secondary agent. But usually most patients are going to get a Zofran. It's a very good agent for dealing with nausea and vomiting. So some of the things you do want to be aware of, and this is actually something that I've probably seen some increasing those commercials where it's like, have you received Zofran during pregnancy, or have you had a QT prolongation related to Zofran, and things like that. So be aware that the QT prolongation is something that I believe it now has a black box warning on it for not really a problem by itself, but when you start to mix multiple meds that have QT prolongation is where you increase your risk for torsades, right? So be aware of that the drug itself is not necessarily benign. For the most part, patients are not going to have any issues with it, but when you start to combine it with other drugs, if you have patients with congenital prolonged QT, this can be an issue. We'll also have some anti-dopaminergic drugs. So these ones are going to be blocking those D2 receptors in the chemoreceptor trigger zone to help limit that nausea vomiting. So metoclopramide or Reglan is going to be kind of a very good one for this. It's kind of an older drug that got used much more frequently for chemo-induced nausea vomiting before the serotonin receptor antagonist really came out. So some other phenothiazines you can see being used frequently for this purpose would include prochlorperazine. I see this used a lot for migraines associated with nausea and vomiting. Haloperidol sometimes is probably kind of a little overkill. But then things like promethazine or Phenergan, right? One of the things to consider is what kind of dosage forms these drugs are available in. So if you imagine if you are very nauseous and you're about to vomit, what type of dosage forms do you think would work for you? IV would be good. PR, per rectum. Good, yeah, so orally disintegrating tablets frequently. So, things like your Zofran, it comes in an orally disintegrating tablet, right? So that's one good option, especially if you don't want to swallow anything. Also has IV forms that are available. Things like Phenergan have a suppository that's good if you are not able to take anything by mouth. Also, IV formulations are always going to be useful here as well. So keep in mind your dosage forms, see what's available to you, and what's going to be working best with your patients, right? I have some patients who even seeing that oral disintegrating tablet, they're like, whoop, and so you have to give them IV or give them something else, give them the options and let them know what they have available to them. So as you might imagine, when you are blocking these dopamine receptors, what do you think are some of the side effects you might see with that? Think back to behavioral, unless you've already repressed all of that. Sedation is going to be a big one, right? So I remember one time I was really sick and my aunt said, here, try this Phenergan. And I said, okay, I'll try that. And I slept for like 12 hours straight. Like, it was pretty good. Huh? I did not throw up. Yeah, well, if I did throw up, I probably would have died. But it worked for that too. So what else? So when you block dopamine, you kind of mimic what disease? Parkinson's, right? So you can still see EPS with these drugs, right? A lot of them, especially the phenothiazines you see here, like promethazine, they have good antimuscarinic activity, so they kind of cancel out a lot of that kind of potent D2 antagonism. But the haloperidol, you're more likely to see that because it's a high potency D2 blocker. Now, I remember talking to a hemonc pharmacist back when I was interning, and they talked about the days before Zofran, and they were saying that when they were treating these patients with things like cisplatin and other kind of high emetogenic drugs, Reglan was it. Like, Reglan was the drug you gave it to, and because the nausea vomiting was so worse, you kept running your doses up and up and up in order to treat this nausea vomiting. And so all these patients, the chemo patients, started developing these dystonic reactions. Some of them had tardive dyskinesia related to this, but again, they didn't want to throw up. So, you know, it's kind of one of those kind of balances of you know, it's kind of a double-edged sword in some manner. So this is why the serotonin receptor antagonists were kind of revolutionary for this, because they got rid of a lot of the side effects and are much, much safer for the most part. But these are good for kind of intermittent, just kind of one-off use. Probably not going to be good for kind of around-the-clock, really significant nausea, vomiting, right? So keep that in mind. Keep in mind your side effects, because it doesn't matter what the indication is, they're going to have the same side effects regardless. Okay, we also have our cannabinoids. So we talked a little bit about medical marijuana. Here are some of the other forms that were FDA approved and are available. So we have dronabinol and we have nabilone, which are kind of synthetic forms of that delta-9 tetrahydrocannabinol, or THC, right? These are oral formulations that are available, and so these are most frequently going to be given to patients who have chemotherapy-induced nausea, vomiting when other agents have failed. What do you think is one of the other kind of beneficial aspects of these drugs? Yeah, they give you the munchies, right? Good thing, especially when you're receiving chemotherapy and you don't want to eat anything and you have nutrition issues and you're starting to waste away. These drugs are good for kind of picking back up your appetite. So this is a good reason for using these as well for those patients. Not nearly as potent as something like, you know, a Zofran or a Phenergan, but they can be useful in conjunction with some of those other things as kind of adjunctive therapy there. Obviously, the side effects are going to be just the same as we saw with the medical marijuana. So, you know, dizziness, hallucinations, mood changes. So keep that in mind. Again, these are nice because they are very kind of pure in the fact that it's just the delta-9 THC. You don't have a lot of the other stuff you would get if you were using the plant product in that regard. Yes. That one you can prescribe. Well, it's a controlled substance, so once that's all squared away, then yes, you'll be able to do that. You know, but again, it's going to be more. You know, you don't want to give it to like every single kind of Joe Schmo out there. Like, it should be relegated more to like, you know, chemotherapy. If you have like, you know, later stage AIDS patients who have kind of wasting, you know, disease, things like that. Like that's where it's going to be more useful. You don't just want to say, oh, you're a little nauseous. Here you go, or you're going on your cruise. Here, have this. This will be fun.
Have a great time.
Yeah, have a great time on your cruise. Like, it's probably not super appropriate. So.
But they're not Schedule 1.
They're not Schedule 1. No. These are, I believe they're Schedule 4s, if memory recalls, right? Because it's still THC. There's still an abuse potential according to the FDA. So they'll still schedule medication. Okay. Another group of medications that are useful are going to be our substance P antagonists. You guys remember where else we talked about substance P? Yeah, for pain, right? That's where our capsaicin cream was working to help kind of desensitize a lot of those nerves. Substance P is also involved in signaling for nausea and vomiting. So if we have drugs that can antagonize the substance P receptors, we can help limit that. And so we have one of the main drugs we see here is a prepotent, or Emend. This one is relegated strictly to high emetogenic drugs for chemotherapy. So it's really the one place you'll see it being used. So, for instance, you'll see it being given, say, for both acute and delayed phase nausea and vomiting. It's one thing you'll see with chemotherapy drugs that, you know, acutely, when you're infusing the drug, you can see some nausea and vomiting associated with that, but some of them will have kind of a delayed period, say 48, 72 hours out, where you can end up seeing kind of just protracted nausea and vomiting. So here we see Emend actually comes in kind of a 3-pill pack where they end up taking one dose early at a higher dose for the acute phase, and they end up taking, like, say, 2 more days worth to help deal with that kind of delayed phase, right? That's going to be more for like things like cisplatin and other really high emetogenic drugs. So the 5-HT receptor antagonists, things like ondansetron, are going to be good, especially for those acute phases, but the substance P antagonist is also beneficial because it works more against the kind of delayed phase nausea, vomiting. Okay. Does interact with CYP3A4, so be aware of that. It can inhibit it, and also induces CYP2C9. So just watch out for those interactions beforehand, especially with those chemo patients. They can be receiving a ton of different drugs, so you want to be able to watch for those. Watch out for those. Okay, so some other agents you may see being used for nausea, vomiting that may not make sense just based on their mechanism of action. So first off, we have corticosteroids. Sometimes you'll see this being used in chemo-induced nausea and vomiting. Like you look at these antiemetic kind of order sets. It's huge, right? It's a huge number of drugs they're going to use. They're going to have the 5-HT3 antagonists. They're going to have a prepotent. They're going to have corticosteroids. They're going to have benzodiazepines. So there's quite a few drugs that go along with this, and they're all kind of treating a different phase or a different kind of aspect of the nausea vomiting. The corticosteroids can be used here. Sometimes you will see things like dexamethasone or prednisone being used most frequently for that. So if you see that being used for nausea vomiting, it's probably for a cancer patient. And then the other thing is that if you know that every time you're going to receive your cisplatin, you're going to throw up, you're going to get this kind of anticipatory kind of anxiety and nausea vomiting associated with that. So some people will throw up even before they've received the drug just because they're so just like kind of ramped up and worried about getting the actual drug and throwing up with that, right? Because who likes to throw up? Nobody. It's horrible, right? No one likes to do that. So these patients get very kind of a lot of anxiety associated with that, and this is where benzodiazepines can help blunt that. So frequently you'll see things like lorazepam or say even alprazolam, which is oral only. They'll be given beforehand to try to limit a lot of that anxiety and hopefully prevent some of that anticipatory nausea and vomiting that occurs there. Okay. You remember how benzodiazepines work? Kind of talked about those before. They work for anxiety. They work with a neurotransmitter. No, not serotonin. Not dopamine. GABA. Remember, use benzodiazepines for seizures too. They enhance GABA. They make GABA bind better to the receptor, open up those channels, and you have more chloride flowing in, hyperpolarize those neurons, right? These are good things to know for the test, which I believe is less than a week away. So I know you have 14 tests in the meantime. You guys are not thinking about that. But anywho, a little bit every day goes a long way. Okay, so how should you choose your antiemetic? So again, it needs to be tailored to your specific patient situation. Not every drug is going to be appropriate for every single patient here. IV and per rectum agents are going to be useful for patients who cannot tolerate oral medications due to the vomiting. So like promethazine, PR, IV is a good option there. Ondansetron IV is a good option. So just keep those dosage forms in mind. And frequently, especially in cases of nausea vomiting, you may need multiple meds on board in order to help manage those patients. So antimuscarinics are going to be better for motion sickness, vertigo, things like that. And then for just any other kind of acute nausea vomiting, the 5-HT3 receptor antagonists are going to be good drugs to go for, right? So a patient comes in for acute gastroenteritis into the ED, what do you think they're going to get? Zofran, right? Absolutely. So Zofran is going to be a nice go-to drug for that. If you're hungover, what are you probably going to get?
Bloody Mary?
Bloody Mary, maybe? Hair of the dog that bit you? No, probably a liter of fluids and some Zofran, right? So Zofran's good, kind of good for most every general kind of nausea, vomiting kind of situation. But, you know, again, think about the situation where you might use the other drugs. One thing I didn't mention with Reglan or metoclopramide is it also has some pro-motility action. So that's actually one of the other places you might see it being used is with something like diabetic gastroparesis because it has pro-motility effects. Okay, which I will talk about right here. So metoclopramide is a big one. Do you guys remember any other drugs that have kind of pro-motility effects? Yeah, erythromycin is the other big one. So those are kind of the two drugs you'll see used for this. Essentially, this one is helping by blocking those dopamine receptors that actually increase acetylcholine release. That works on the muscarinic receptors in the GI tract to kind of move things along. So again, good for gastroparesis, good sometimes for GERD if they're having kind of delayed gastric emptying, and that's kind of the source of the GERD. But again, just think of those side effects we mentioned before. Very similar to the other phenothiazines we talked about in the antipsychotic section. High doses, chronic use, you're going to see dystonic reactions, EPS, and that tardive dyskinesia. I mentioned erythromycin works on the motilin receptors within the GI tract, and that's another good prokinetic agent. So it's usually either one or the other. I don't see both of those together frequently. But what do you think is a potential side effect from using pro-motility agents?
Diarrhea.
Diarrhea. Yeah, absolutely. Diarrhea is the one thing you would expect to see there. Good. Okay, so then moving on, we'll talk about our laxatives. All right, so what are some common causes of constipation? You guys think of any? Besides what I have on the...
Calcium.
Calcium's a big one, yep. Hypercalcemia, absolutely. Opioids is a huge one. Huge, huge, huge one. You guys remember how we treat opioid-induced constipation? It's a fun saying. Mush and push, right? You got to use dual mechanisms to treat opioid-induced constipation. We'll talk about what those are in just a little bit. Anticholinergics can do this as well. right? Because antimuscarinic activity on the GI tract slows everything down. Antacids can do this. Iron is certainly notorious for doing this. One of the things I was experiencing with my child is, especially when a child is breastfed, they don't typically get enough iron in their diet, and so you worry about anemia for them, right? So then you feed them solids, especially stuff that has iron in it, and we could not figure out why all of a sudden she got super constipated. And then her mom's a nurse, or her grandma, the baby's grandma, is a nurse. She was like, "Well, what do you think is in all that food you're giving her?" It's like, "Oh, it's iron fortified." Oh, okay, that would make sense, right? So iron is another big cause of constipation that you can see there. So lots of prunes, though. Prunes help out. Calcium channel blockers can be another big one as well, because again, they can kind of inhibit that smooth muscle constriction, slow things down, and cause constipation. So our goals here, hopefully relieve the symptoms, reestablish any kind of normal bowel habits, and then increase quality of life. Okay. So some of the mechanisms we can see being used for these laxatives include increasing motility of the GI tract. We can increase the water content of the stool, and then also decrease colonic water and sodium chloride absorption. Right. So whatever water is there, try to keep it there in the GI tract. Because as we know, if we increase the amount of water in the colon, what does that do?
Makes poop more liquid.
It makes poop more liquid, but what does that do? Like, what does that kind of stimulate the colon to do? Get rid of it. That's it. Knock down the water. Sorry. Yeah. So anyway, so it kind of gets everything moving, right? So that the stretch receptors within the colon, as it gets kind of filled up with more fluid or more solid matter, it will kind of stimulate things to move forward, right? It's all the stretch receptors. So those are going to be some of the ways that these laxatives are going to be working. Some other indications you may see for laxatives include things like bowel cleanouts, right? So you just want to basically clean out the entire bowel for something like a colonoscopy or an EGD. If you need to hasten bowel excretions of toxins, so for instance, if you had someone who was, say, coming across the border with several packets full of, say, cocaine in their GI tract, you can give them some therapy to help eliminate all of that. I see that much more often, like Miami and places like that. Sometimes for post-operative stimulation, because especially after, especially abdominal surgery, you can see things kind of slow down a bit. They received a lot of opioids. This is useful here. Patient has CV disease, you don't want to have them straining too much, because that can do what? Hemorrhoids. What else can I do for cardiovascular patients?
Increased blood pressure.
Increased blood pressure, potentially aneurysm, but like the vasovagal, that can be problematic for some of the cardiovascular patients. So, and then just temporary relief of constipation. So, obviously, if they have any kind of underlying bowel conditions, they need to get that sorted out first prior to kind of self-prescribing a lot of these drugs. So general side effects, you're going to see nausea, abdominal cramps, diarrhea associated with this. And then you can also run into this issue with more chronic use of these laxatives. We're going to see that a lot of these, you want to use more kind of intermittently. You don't want to necessarily use all the time. We'll talk about some that are safe for that. But the problem is you can get this cathartic colon syndrome that can develop the kind of overuse of these laxatives, where they have this kind of mucosal inflammation, atrophy of the outer muscle layers, and damage to the actual nervous system of the GI tract, and kind of prevent them from really being able to defecate on their own, right? We don't want to do this because again, they're basically going to have to use these chronically just to be able to keep themselves going. So we'll talk about specific ones that can be issues with that. So again, we will mention the three categories. So those that can soften the feces in 1 to 3 days. So these include your bulk forming agents. Can you guys think of any examples of those?
Psyllium husk.
Yeah, psyllium husk, fiber is going to be a good thing there. We'll talk about our emollients, right? So that's kind of the mush that we mentioned in the opioid-induced constipation treatment. And then our osmotic agents. You guys think of any of those? PEG, yeah, PEG. So polyethylene glycol, Miralax is the common brand name for that. So those are good for helping to kind of soften the feces in the first couple days. You're going to have something that will result in kind of soft or semi-fluid stool within 6 to 12 hours. These are going to be your stimulant laxatives. That's like Senna. It's going to be working a lot more quickly. And then those are going to cause watery evacuation. That was the textbook's term, not mine. Within 1 to 6 hours, right? So these are your kind of bowel cleanouts. These are where you get your osmotic laxatives is where, normally Miralax is used for kind of occasional relief of constipation, something like Go Lightly, which is a big 4-liter tub of polyethylene glycol. That's meant to just get everything going, right? So that's where you're going to be using those. Enemas can be useful here as well. You guys think of any enema products? Yeah, Fleet's enemas, which is usually what? Sometimes saline. You can do saline. Usually sodium phosphate solution can do that. Soap suds, enemas, that could all be possible. And like I mentioned, this bowel clean out. So those are kind of the three big groups as far as how quickly they're going to be working for your patient. So the bulk forming, these are typically non-digestible dietary fibers. So this can include anything from psyllium, methylcellulose. Those are the most common ones you're going to run into. Basically, you got to mix them with water before they're going to take it, because it usually comes in a powdered form in a lot of cases. And basically, by increasing water content, increases the bulk of the stool. This again signals those stretch receptors to increase motility. The other thing you need to worry about, though, is obviously you're going to have some GI upset from this, but also it can bind medication. So again, separate these out by a few hours in order to help avoid chelating anything else you might want to be absorbing during that time frame. The stool softeners, again, these are the emollients. Mineral oil is a good one to help here. Glycerin, probably the most common one you're going to see being used is docusate, right? So colace. Do you guys know elsewhere that you can use docusate in the body? Yeah, earwax. Yeah, absolutely. So you can put docusate in the ear, and that actually helps to break up some of the earwax, and if you have an impaction there. So that's one thing you might see in the PED. And again, once they emulsify the stool, it helps to kind of lubricate it, increase the water content, and make it for easier passing of those stools, right? So if you have those patients that have really kind of hard, dry kind of stools, like these are going to be good agents for them to kind of help lubricate things and pass them more easily. Next up, you have your stimulants or irritants. These are going to be working more specifically on the receptors in the GI tract to help stimulate peristalsis. They don't necessarily do anything with water content necessarily, but just by directly stimulating those receptors, increase motility. Senna and bisacodyl are probably your most common ones you're going to see there. Castor oil does not get used too frequently anymore, but it's kind of one of those home remedies like your grandma might try to give you if you're constipated. But Senna and bisacodyl are the main ones there. Obviously, big side effects are just going to be the GI upset, and these ones are the ones that are a little bit more kind of habit forming, because again, normally your kind of CNS is telling the GI tract, hey, defecate, or the GI tract is kind of managing that. If you chronically are using these stimulants, that will kind of diminish that signal, and so you find that patients kind of become more tolerant to this, and they kind of have to have the stimulant around to continue normal defecation. So this is one of those ones that we recommend more for kind of just kind of intermittent use, not for chronic daily use, right? You're not going to see a problem with like a stool softener or a bulk forming agent like that, but the stimulants for sure.
So what would you do? Would you wean them off with another laxative, or?
I would probably try to titrate down their dose to see how they respond to that, while also using something like a bulk forming or osmotic laxative just to kind of try to keep things moving on their own.
Same thing with smoking cessation. They're going to have the same problem. So you would just titrate the dose down and
try to give them something else to kind of help them with the symptoms. Yep, very similar. So don't get hooked on laxatives.
Or cigarettes.
Or cigarettes. It's a key thing. It's a real pain in the butt if you do. So. Okay. So next you have your osmotic agents. So these are going to be ones that can be useful for kind of rapid evacuation. So something like mag sulfate, mag hydroxide, that milk of magnesia, I call it like the green rocket. Sometimes you'll see it being called. Lactulose, mannitol can also be used. Basically, it's just a really kind of hyperized osmotic solution, and water likes to go from areas of high concentration to low concentration. So it's going to try to dilute out those solutes, and so it's going to draw water into the colon, which increases peristalsis, right? You can also see sodium phosphate being used here, polyethylene glycol. You can use some of these, especially like the polyethylene glycol, in more kind of like daily uses at smaller doses. So for instance, a normal dose of Miralax is like 17 grams a day. You can use that just for normal kind of maintenance of normal defecation. But if you're using like really big doses, that's where you can draw a ton of water in. That's where the Go Lightly comes in, and you just pass everything through. One of the things my talk students frequently find very funny is that when we have a patient who is a body packer, is one of those patients who have ingested, say, lots of packets of cocaine, and you're trying to flush them out, we'll frequently give them a therapy called Go Darkly, where we actually give them charcoal beforehand in case any of the packets rupture, because you want to try to prevent that drug from being absorbed. Give them that first, and then you follow it with the Go Lightly to flush everything through. So we call it Go Darkly. If you ever hear that term, I use that's what it is. So Again, these some of these you'll see being administered rectally as an enema. So especially like the sodium phosphate is probably the more frequent one you see used there, like the Fleet's enema. You do not want to administer anything rectally to neutropenic patients. You guys know why?
Perforation.
Yeah, you worry about perforation, so don't do that. If you have like a cancer patient who's on chemotherapy and they're neutropenic, don't give anything rectally. So again, you don't want to do rectal temperatures, anything like that. So avoid that. And then also one of the big problems you run into, especially when using electrolyte-based solutions like sodium phosphate, is that in the very old and the very young, you can run into imbalances in their electrolytes. So there's been some cases of both young children and old patients dying from hyperphosphatemia after giving these enemas. And usually it's not just one, but if you kind of give recurrent, multiple uses, this is where you run into problems. Okay, so just be aware of that. Usually otherwise, teenagers or, adults, healthy patients, usually don't have a problem with this, but it's the extremes of age where you can run into that problem. So, what's our treatment algorithm for constipation? How do we manage these patients? So, one, treat to the specific cause, right? So, if it's an opioid, what could you do? Yeah, so one, you could try maybe stopping the opioid. Maybe they can use something like an NSAID instead for their pain, right? That might not be possible, but it's something to consider. What are some other things we mentioned that you can use for opioid-induced constipation? Yeah, so remember we talked about the peripheral opioid blocker, so that's like methyl naltrexone, the alvimipan. There's another one that was on that list, but yeah, so all of those can be used to peripherally block those opioid receptors. So again, going back to the root cause of the problem, right? If it's something to do with diet or medications they're taking, maybe try to switch the formulation or switch the medications they're consuming. So if it's iron-based or calcium or something like that, those are usually hopefully things you can try to address initially. So other things you can do dietary-wise is increase fiber intake, so that can always be useful. Water intake as well. They mentioned a lot of, especially kids, are chronically constipated. A lot of it is due to dehydration. They don't get enough water routinely to kind of lubricate the stool, so that can be a big problem. I'll never forget one of my cousins called me up. His daughter was probably like 2 at the time, and he goes, "Oh my gosh, I think she's going to die. We're going to the ER right now. She's in just the worst stomach pain of her entire life." And I go, "She's constipated." And he's like, I don't think so. She's really in a lot of pain. I think she's in trouble." And I was like, "She's constipated." Sure enough, called me back an hour later. They gave her an enema. Now she feels better. Like, it's amazing, right? So that's usually one of the big problems. So dietary modification is huge and can be very, very effective here. If not, you can always try using something like an osmotic laxative like a polyethylene glycol, an emollient like Docusate. Try it for 2 to 4 weeks, see how they respond to that. Really don't want to try to add on the stimulant unless they haven't really had a bowel movement for say like 2 days or so. 2 days or longer, that's where you may need to just kind of get things moving along. So stimulant can be useful for those kind of really intermittent cases. I mentioned the opioid receptor antagonist, and then for osmotic enemas, for acute evacuation of the bowels. So as they come to the ER, come to the clinic, and they're really in a lot of pain, that's where you can use the enemas to kind of just give them an initial clean out. But avoid those phosphate-containing ones in the old and young patients. So there's a couple of anti-diarrheal agents that you can potentially use. So these help to enhance water absorption and decrease the GI motility. So there's a couple of different ones here. These are actual peripheral opioid agonists. They don't get into the CNS to cause any problems there. But you have diphenoxylate and loperamide. And so interestingly enough, diphenoxylate is actually compounded with atropine. Atropine itself, what type of drug is that? It speeds up the heart. It's an anti-muscarinic drug, right? So it blocks muscarinic receptors. And so normally if you give it orally, it doesn't get absorbed, right? But this is actually one of those cases where they're trying to avoid abuse of some of these drugs. And so diphenoxylate, if you inject it, especially high doses, you can actually see some of those opioid effects. And so what they did was they compounded it with atropine, because if you take atropine, you don't need it, you feel really, really crappy, right? Because it causes all those anticholinergic side effects. So this is one of those cases where it's an abuse deterrent by mixing it with something you would not want to inject yourself with, right? But both of them are going to be useful for treating diarrhea. Again, if it's more of an infectious case of diarrhea, you may not necessarily want to use these because
get that stuff out.
Yeah, you're trying to get those bacteria out of there, right? So again, it may not be useful in some of those cases. Obviously, adverse effects include constipation, so that can be one problem there. Interestingly enough, I had one case, a tox case, where this lady, one of the things, the reason why loperamide does not get into the CNS to cause its opioid effects is because of that protein PGP, that P-glycoprotein. It actually, any drug that crosses the blood-brain barrier gets spit back out by that PGP into the periphery. And so this lady was either she looked up some interesting websites, or she was kind of a street pharmacist, and she said, well, I can inhibit PGP if I take cimetidine. Right? We said cimetidine is a big CYP3A4 inhibitor, also inhibits PGP. So she took a ton of loperamide, took a ton of Tagamet at the same time, inhibited that PGP in order to increase CNS concentrations of that drug to get high. So it did not turn out too well for her. She ended up going into torsades and ended up being in ICU for a couple weeks, but you'll never be, you'll always be surprised by the lengths that some of these people go to achieve a high. So other things that can be useful for diarrhea include Pepto-Bismol. So bismuth subsalicylate can be useful for this as well by inhibiting things like intestinal secretions. This may be more useful in infectious diarrhea, so that may be used there because it's not directly kind of halting peristalsis like those opioids were. This one, again, needs to be taken frequently, and do want to worry about salicylate toxicity for some of those patients, especially if they're taking kind of all the time. So I'll cut it here for today. Do you guys have any questions before I let you go? So everyone that needs to use the restroom now? Just kidding. All right, I will see you guys next time.